Good evening, everyone. Welcome to the 10th episode of the VRchannel from the Vitreo-Retinal Society of the Philippines. I'm Joan Loy, your host for this evening. I'm delighted to share tonight's stage with my co-host, Dr. Roy Cagampang.
Thanks, Joanne. Good evening, everyone. I'm thrilled to be with you tonight. If you are joining us for the first time, the VRchannel is a platform created by the Vitreo-Retinal Society of the Philippines to allow us to continue to share updates about various retinal conditions amidst our new normal. In the last episode, we certainly gained helpful tips and tricks in dealing with a phakic eye. For tonight, we will be tackling a red, hot, painful ball that makes a lot of ophthalmologists uneasy.
That's right, Roy. In keeping with our global theme, our special guest lecturer is joining us from UK. Dr. Giampaolo Gini will discuss endophthalmitis and the European Vitreo-Retinal Society Endophthalmitis Study.
Joanne, it's been a while since a large publication on endophthalmitis has been made. But before we get to that, let me take this opportunity to extend our thanks to our industry partner, Bausch & Lomb, for supporting this episode. Please welcome Mr. Emmanuel Flores, Technical and Support Manager for Bausch & Lomb. He will be presenting the Stellaris PC pressurized infusion system later tonight. Also joining us is Ms. Maria Luisa Libanan, Product Manager of Bausch & Lomb Pharma and Surgical. And thank you for gracing us with your presence tonight. Ms. Libanan, may we ask for a few words from you?
Hi, good evening, doctors. In behalf of Metro Drug and Bausch & Lomb, can you hear me?
Yes, clear.
Sorry. In behalf of Metro Drug and Bausch & Lomb, we would like to thank you for giving us this opportunity to be part of the VRSP VRchannel episode 10. I would also like to express my heartfelt gratitude to all of you doctors for your ending support to Bausch & Lomb. Rest assured of our unwavering commitment to supporting you from this year and forward. And stay safe, everyone.
Thank you, Miss Lizzie.
Thank you, Dr.
Okay, thank you so much again to Bausch & Lomb for your support. No? Before we proceed to the lecture, may we ask everyone to kindly scan the QR code flashed on the screen using your smartphones. So just like in the previous episodes, our sessions, they are interactive as always. So the QR code will take you to the site where you may participate in the polls and post questions as well. So you can find this code throughout the session on the lower right portion of your screen. So tonight's poll is about your threshold for deciding when to do pars plana vitrectomy in endophthalmitis cases. Share with us your thoughts on this, please.
You may also post questions and comments in the Slido app on the YouTube chat box for those watching on YouTube. We will try to address these in the open forum part of the session. Now, let's move on to the lecture proper. Ciao! Our special guest for tonight has a huge global presence, a recognized clinician, a surgeon, and an educator. He has been invited to speak in over 400 meetings worldwide. He has vast surgical experience and a total of 36,000 surgeries anterior to posterior and counting, and has earned him invitations to perform live surgery meetings and demonstrate techniques in at least 15 countries. He has garnered 900 hours of activity meetings in almost all countries too. He is also multi-awarded, the coveted Italian Ophthalmological Society Award 2 times, American Society of Retina Specialists Rice-Buckler Award twice, and the Royal College of Ophthalmologists Richard Collins Award. He also served as a faculty member of the European Vitreo-Retinal Training School in Bremen, Germany, contributing the training of over 1,000 surgeons from all over the world. He served as a board member and secretary of the European Vitreo-Retinal Society, or EVRS, of which he is the current president. He is also known internationally as being one of the first surgeons to challenge the results of the early vitrectomy study for the treatment of endophthalmitis. The paper was titled, Vitrectomy for Endophthalmitis by Kuhn and Gini, published in the journal Ophthalmology in 2006. In his native country, Italy, he is a lecturer for the Italian General Practitioners Association and scientific advisor for the Italian Ophthalmological Association. Another feather in his cap is the recent appointment as the Vice Liaison Officer in Europe for the American Society of Retina Specialists. Presently, he is a consultant vitreoretinal surgeon at Western Sussex NHS University Trust and also holds private practice at the Nuffield Hospital in Haywards Health and Opera Hospitals in Hampshire. Without further ado, it is my honor and pleasure to introduce Giampaolo Gini.
Thank you so much, Roy. Thank you. I just want to express my gratitude to Dr. Joan Loy and to the organizing committee for giving me this opportunity, this great pleasure. It really is an honor. My only regret, as I said before, is not being in the Philippines personally. I know it's a beautiful country and I would really like to be there instead of being in gray and rainy England at the moment. Today, as president of the European Vitreo-Retinal Society, I have a duty to introduce the society itself because I think it has done some good things and I would like to bring these to everybody's attention. So let me start by sharing my screen with you and giving you this presentation, which should. It's not the one that I wanted to. This is it. So we can start by sharing this. If I can get to the share button, here we are. Can you see my screen? I think you can.
Yes.
So now I have put on that logo simply because it is the most representative of the society. This is what most people would hear during our meetings as they were called from their coffee breaks back to the session where we would be doing some more serious work. And this is also what most students at the European Vitreo-Retinal Training School would hear when time to begin their lessons was commencing. So I put this as a special treat for Roy, because he, Dr. Kakenbank, because he has obviously been very active in our society, and I'm sure he remembers this little motto that we have, this little music that we have. So let me just say what the state of vitreoretinal surgery was like at the beginning of the century. So we had some pioneers, as you know. The innovator was Macumer in the 1970s, and then some pioneers which picked up the work that Macumer had set down. Unfortunately, Macumer died early, and these were people on both sides of the ocean. Now, unfortunately, the ones that were most known were in the US and Europe. I'm sure there are others throughout the world, but there's a cultural sometimes there is a cultural rift between different countries, especially in the past when globalization was not a reality like it is today. So we had people like Steve Charles, Harry Flynn, Stanley Chang on one side of the ocean in the US, and then in Europe we had some other important names such as Zivonovich, Gregor in the UK, Delfiume de Malfetta in Italy, and these were really, I would say, the pioneers, people that were writing the history of vitreoretinal surgery as it is today. After that, so it was for some time, it was, I think, a reality which was limited to only a few centers in the world. And so people would actually travel long distances to be able to have surgery in these centers. Many times it was a desperate surgery because there was nothing else that could be done, but they tried this as a last resort. Then vitreoretinal surgery became more known. It perfected itself thanks to better knowledge, thanks to the industry. And we started having what I call second generation vitreoretinal surgeons, the ones from the at the beginning of the new century, so from the 2000s onwards. And somewhere in between somewhere in between these two dates, we have the introduction of people that were in between the two generations. I would consider myself and others among these. And we realized that we needed to train, we needed to somehow bring what were the pioneering work of people like Charles and so on to the new generation of vitreoretinal surgeons that were going to be massively employing this technique. And so this is how EVRS is born. We decided that a society that would have a new approach would be created. And this was in the year 2001. And the aims of the society were that to connect individual surgeons, so to allow the sharing of everyday experiences, doubts, questions, solutions. So many times you could just pick up the phone really and call one of these colleagues in those days and say, I have a case, how would you solve it? And this led to a special way of doing things. So we called it My Way. And everybody that had ideas was invited to share them with everybody else. And this led to two important congresses or meetings of the society, which were in Porto and in Venice. And they were actually My Way Part 1, where common situations were discussed, and My Way Part 2 were complicated and more and situations that were actually rare were discussed. So two different meetings in 2 different years, and all based on the same philosophy: my way. How do I approach a problem differently from someone else? The second aim of the society was to share the knowledge among peers. How did we do that? We did that, as I said before, through meetings where no one was too young or too inexperienced to get up and talk and bring his or her ideas, and where no one was more important than anybody else. So I would say, not top-down approach, but a very horizontal approach to learning. The website was also quite revolutionary, as we introduced a number of tutorials and surgical videos which were contributed by all members and for use to all members. And finally, we decided that it was necessary to create a full immersion 2-week vitreoretinal training school, which would give aspiring vitreoretinal surgeons or vitreoretinal surgeons with lesser experience an opportunity to see the techniques, to discuss problems, and to learn in general. So this is a 2-week full immersion. And I must say that the society has grown. Today, it has over 700 members from 90 different nations, and we have some very, very good friends. And I'd like to, among these, I would like to name Dr. Kakambang, who you see here in a very early photo when he was very, very slim. He still is, but he was very young. And this is in Bremen, where he is with the mayor of Bremen at the European Vitreo-Retinal Training School. Roy was with us. He he's a very committed member. He was with us. He went to Ravenna with the late Dr. Forlini for a period of intense training. Dr. Forlini was a real innovator, especially in trauma surgery. And you can see this newspaper clip with Dr. Kakampang, and he went on to get center stage, and he presented his work at our meetings. He was very, very active, went on to become a moderator, and finally also shared some very important responsibilities, such as that of judging the videos in our video competition, which we regard as being a real centerpiece of our meetings. So, so thank you so much. It is he is a true friend of our society, and we owe him quite a lot. Thank you. Now, if you look at our website, this is how you will find it. And I would like, many of you probably have gone there already. For those who haven't, you can find what I'm really happy about. You can look at the EVpedia, which has many videos, as I told you, but you can also look at the studies. Every year, EVRS has carried out one specific study, starting from 2011, where a retinal detachment study was carried out, then macular edema, macular hole, optic pit, CSCR, floaters, and finally endophthalmitis in 2017. And this is what we are going to be talking about today. Now, the study, let me tell you, is extremely complex. It has a lot of data, and going through it in detail would require a very long time. There have been 2 publications. Some others will follow because there is so much data that has to be analyzed. And obviously, it, like the early vitrectomy study, which led to several publications back in the 90s, this study as well is leading to a number of publications, because there is so much data that can be used and collected. So I won't really go into detail about the study itself, because it would take too long, and I invite you to do so yourselves. But I will give you an idea of why it was created, and the main that it reached. What I would do is a more practical approach today of why I think vitrectomy should be the way forward, or the golden standard to dealing with endophthalmitis. So without losing any more time, let me start with the EVRS study. This has several, obviously, steps. We start with the baseline characteristics, and then primary, secondary, and tertiary treatment were considered. The final status of the eye. We try to grind down all this data with a multivariate analysis to draw some final conclusions, which in some cases were productive. In other cases, as you would expect, having such a large number of participants and data, there was somewhat inconclusive, but we'll see as we go along. So the number of patients was significant, 253 patients. The initial EVS study was around 400, so we're close to an acceptable number. 64 doctors from 24 countries, and I'm happy to say that the Philippines, as you see, were among those countries. So there was a contribution from the Philippines as well. The aim of the survey was essentially to understand what course of action is taken by ophthalmologists throughout the world when they face post-interventional endophthalmitis of any nature, be it early onset or delayed onset. And also, we wanted to understand, if possible, how different approaches could determine the final outcome for the patient. As I said before, there was a large amount of data, as you can imagine, many patients, different countries, different doctors, different levels of experience and know-how and possibilities. So various types of surgical procedures were involved, and within each procedure there were also a number of variables which made the study even a bit more complex. To give you just the main ideas, as you would expect, we have cataract surgery, which is responsible for most of our cases of endophthalmitis. So we look at about more than half, 60%, were related to cataract surgery. But you'd be surprised how we also have an incidence of 11%, 12% endophthalmitis in vitrectomy, and just about the same number as you would expect for intravitreal injections. So whenever we go to the back of the eye, there is a chance, there is a possibility of having infection. And we'll talk about this a bit later. Other procedures obviously have a lesser incidence than the two combined, which would account for about 90% of our endophthalmitis cases. 162 of these 253 eyes had cataract-related surgery, of which about 95% were primary cataract surgery with routine phaco and IOL implant, and only a minority were related to secondary IOL implants or with no implants at all. We also looked at whether it was routine throughout the world to use intracameral prophylaxis and with antibiotics, and we saw that it was not. In about half of these cases, no prophylaxis was used. So we found that this is not a routine procedure, but we also found that if you look at these numbers in a different way, that the prophylaxis itself was not really always that efficient as we would like to believe. So despite the use of antibiotics in intracamerally, we still had obviously endophthalmitis developing in a number of cases. Was this cataract surgery complicated by incidents along the way? Yes, it was, and with an incidence which is actually greater than what we generally have for even for standard phaco. So we had about a 13% incidence of posterior capsule rupture or vitreous loss, which is a bit higher than the 5-6% which we would generally be expecting. Why this was, we could not say. Possibly because the surgeons were operating on different varieties of eyes, maybe with very hard cataracts or more difficult eyes. And many surgeons were also giving these cases to their juniors. So this could have been another issue, but it is interesting to see that there was a higher incidence of posterior capsule rupture than generally expected. Whether that could influence the endophthalmitis ratio or not, we really can't say. Then there was a number of as we said before, of eyes which underwent different procedures, and we said already that the percentages of these were mostly related to PPV or intravitreal injection, with a minority being occupied by cornea surgery. We then looked at the eyes that developed endophthalmitis, and we tried to set down some parameters which we thought were to be of interest, obviously visual acuity being one of them, but also the way the eye presented itself. So if the cornea was hazy, if iris details could be seen, and if the lens was visible or not. Also, the extent of the hypopyon was recorded, but and the intensity of pain. We shall see that the intensity of pain does have quite an important role in the final prognosis. So at presentation, we had that most of the eyes were eyes that could actually had some use of vision. So they had either more than half of them had a greater than counting fingers vision, and about 40% had light perception. We shall see, and I just like to make this point because I think it's an important point, that light perception or per se is not the difference between being able, for example, to count fingers or light perception is not that great, because as you all know very well, even a small amount of fibrin or in the anterior chamber or vitreous haze can really determine a difference in the visual acuity without that being necessarily an indicator of severity of the infection itself. So, for example, if you have a case of endophthalmitis in an eye which has received an intravitreal injection, you could have a more serious infection than in an eye which and a better visual acuity for in the early stages than an eye which has had cataract surgery and where it has significant fibrin in the anterior chamber and has a lower visual acuity, but perhaps a better prognosis. So we then looked at the state of the retina. Was the retina visible or not visible? Was it attached or not? And when we finally got to see the retina, either at the slit lamp before the operation or during a vitrectomy, if that was carried out, was endophthalmitis retinopathy present or was maculopathy present? Now, primary treatment took into account the time elapsed between the diagnosis and the treatment itself. And then we looked at the sort of treatment which is offered to these patients. Were they treated with only intravitreal injections? Were they treated with vitrectomy? Or did they have a combination of the two procedures? And then there's other data of lesser importance, such as the use of intravitreal steroids or not, and the use of systemic steroids or antibiotics, and so forth. There's a lot of data that essentially told us that people do throughout the world, surgeons deal with this problem in many, many different ways. Each surgeon adding something that they think will make the prognosis better. So if we try to boil down what the primary treatment was and the overall treatment strategy, we see that about 40% of the eyes were treated with vitrectomy. About the same number were treated with intravitreal antibiotics, and a combination of the two were used in about 20% of other cases. Fortunately, only a minority had a simple observation and nothing else. So when we were looking at the intravitreal antibiotic injection, the question was which antibiotics were used, what dosage were they used at, was a vitreous tap used before the introduction of the antibiotics. And then if we went on to vitrectomy, we considered many other variables, such as the extent of the vitrectomy, whether a capsulectomy was performed or not, if the IOL was removed or not, what gauge was used, as I said before, if the retina was involved and to what extent, if during the surgery PVD was induced or not, and finally, what sort of tamponade was selected for at the end of the surgery. So what we found for the intravitreal antibiotic injection, and I won't go into the details again because the charts are very extensive, and they really we can simply look at the end result. And this is what we found, that most surgeons use vancomycin and ceftazidime. There was a wide variation in the dosage. So this went from 0.5 to 2 milligrams per 0.1 mils of vancomycin, and from 1 to 3 milligrams per 0.1 mils of KEF for most patients. What about vitreous tap? Well, interestingly enough, this was almost always, but not always, performed. And again, this is something which has to be underlined, because the golden standard would be to have a vitreous tap performed before doing anything else. So if we look at the primary treatment for vitrectomy, the extent of the vitrectomy was generally large for in most cases, 80% of surgeons opting to carry out an extensive vitrectomy, and a core vitrectomy being limited only to a minority of the the surgeons, and therefore of the patients. As far as tamponade was concerned, we saw that in about 30% of the final outcomes, silicone oil tamponade was used, whereas no tamponade was used in the majority of cases. And we will have an opportunity to, I think, to discuss this in our discussion session. Looking at the final status, we analyze the visual acuity, and I think an encouraging result is that most of the patients, about almost 60% of the patients, had some sort of useful visual acuity, which is certainly greater than 0.5, and between 0.5 and 0.5, 0.2 and 0.5. So, regarding the retina, the final status, we looked at whether it was attached, and in most of our cases, it was. Almost 90% of the retinas were found to be attached. We can't say in about 10% whether this was a final result or not, because silicone oil was still present, and a minority of the cases we had a partially or detached retina. Another interesting and important outcome obviously had to do with intraocular pressure, because we know that the ciliary body is affected in endophthalmitis, and this can lead to fibrosis and hypofunctioning of the ciliary body itself, and therefore we looked at the incidence of hypotony, defining hypotony as intraocular pressure which was lower than 10 millimeters of mercury. And we found that hypotony was present in a significant number of these cases. About 90% of these patients had a low intraocular pressure. Eyeball anatomy also was of paramount importance, and we found this to be normal in about 90% of the cases, and we lost the remaining 10%, whether they were because they were pre-thisical, or they were thisical, or they had to be enucleated or eviscerated because of an ongoing pain. or because the cosmetic situation, simply the patient requested for the eye to be removed. Now, we took all this data, we put it in our grinder, which was represented by a team of statisticians, which EVRS paid for. And we ground all this analysis and came out with some conclusions, which I want to share with you. So looking at the comparison between the initial and the final visual acuity, you could see that patients that had no light perception, about half of these patients ended up with no light perception, and about half of these ended up with hand movement. Patients that came to us with light perception, so there was a scope here to operate on these eyes, because at least they got something out of the operation itself. Again, as I said before, visual acuity is important, definitely, but simply because an eye has little light perception, I don't think one should give up on this eye, and the study seems to prove that this is the correct way of reasoning. Light perception, patients that came with light perception ended up with, unfortunately, no light perception, so there is the possibility for this to happen, whether this was related to the surgery or simply because it was too late to intervene anyway. I don't know, and I don't think anybody can say at this stage. But the patients that had light perception, we lost about 10% of these, but the remaining actually got either light perception or better, so had movement 0.1, between 0.2 and 0.5, or in some cases greater than 0.5. And you can see the numbers here, which are rather encouraging. So if we look at a useful visual acuity, which I would define between 0.2 and greater than, we have about a 40% of these patients with light perception, which can actually do quite well. Patients that had hand movement obviously had an even greater improvement, and you can see that if we again look at the useful vision for these patients, we are well over 60%, and the data continues to improve as our starting point obviously is a better one. So if we're looking at 0.1 starting point, we see that we have a very high and very good result as far as visual acuity, useful visual acuity is concerned, and so forth. So what seems to obviously appear from this first set of data, which I think is intuitive, is that if you have a better starting point, you end up with a better visual acuity, which it goes to say something about the importance of time in dealing with these cases, as we will have a chance to see later on. The earlier we deal with these people, the better, obviously, the visual outcome. We also looked at some prognostic factors for the improvement of a visual acuity, and we use logistic regression to evaluate the best strategy to improve the visual acuity. And the response that the surgeons were asked to give was used as a binary variable. So it was either, was the final acuity greater than counting fingers or not? And in this first analysis, some potential prognostic factors were considered, among which age, cataract surgery, visual acuity, whether the iris was visible or not, the conditions of the cornea, whether red reflex of the fundus was visible or not, if the retina was visible, and the state of the disc, the macula, the retina, and finally, as I said before, which I think is an important factor, just how painful this, the amount of pain that the patient was experiencing. We also looked at, so the probability of final visual acuity to be greater than counting fingers, we found was positively associated with, as we said before, an initial visual acuity which was greater than counting fingers. If the cornea was clear at presentation, the absence of pain at presentations, and the use of vitrectomy as opposed to intravitreal antibiotics. Now, I have to say that the significance of this data, of this last statement, is not as great statistically as we would like. But there is a suggestion that vitrectomy, I would not say that we have overwhelming numbers or overwhelming evidence of this, but the suggestion is from the numbers is that vitrectomy is more effective than intravitreal antibiotics alone, and this because statistically it is significant. Another set of data which we analyzed was the logistic. It was essentially based on if the endophthalmitis retinopathy was present, and what gauge sutures we're using, what sort of tamponade was used at the end of the vitrectomy, and whether the antibiotics were used throughout the surgery or not. So vitrectomy also has its variables according to how it is performed. And we found that visual acuity was positively associated with the use of a small gauge rather than a standard gauge, whereas it was negatively associated, obviously, with the presence of retinopathy and maculopathy, but also it was negatively affected by the use of silicone oil tamponade. As I said before, what I really would have liked the study to show unequivocally was that vitrectomy was far superior to any other approach. But the numbers don't lie. And so as I said, there was an indication, but not an overwhelming set of data that suggested this. Now, why this would be is probably due to two factors. One is the study design. This was more of a survey to collect a great number of information and to know what people were doing when facing endophthalmitis. And the second, I think, which was really significant, is the fact that intravitreal antibiotics only and vitrectomy only are biased by a time factor, because vitrectomies within 1 week from onset were included in the vitrectomy group. Now, 1 week is a long time, and I think that most of the damage is done by the time you go in after 1 week. So that may be one of the reasons why, well, as I said, the study was biased by this time factor. Let me say what I think should be the approach to the problem when you do have an endophthalmitis. This is something which I have been promoting for several years, as Dr. Kakampan told you. The first publications with Professor Kuhn are now more than 10 years old, but the basic message that was given in those early works is still true today. So you all know that we have several types of endophthalmitis, endogenous and exogenous. If we look at the exogenous group, we would be dealing with essentially either trauma or iatrogenic. You can have late onset, for example, when you have filtration blebs which get infected, or you can have an early onset, as we have discussed before, with anterior segment surgery or posterior segment surgery. There are a number of microorganisms involved. I don't want to bore you with data which you have already. They change roughly with the type of endophthalmitis which you are dealing with, whether it's postoperative or post-traumatic or associated with keratitis or intravitreal injections and endogenous. Generally, when we're dealing with cataract surgery, as you all know, some of the most common ones are the staphylococci and whether they are epidermidis or aureus, and some of the streptococcus species. Only late onset may be related to some sort of staphylococci or P. acnes, but these are late onset endophthalmitis. So, how should we consider endophthalmitis? I think that regardless of the nature of the infection, you should be regarding this as a surgical rather than a medical emergency. The early vitrectomy study, EVRS, which was carried out in 1995, which was a prospective randomized study in around 400 patients that presented with postoperative endophthalmitis, essentially reached a conclusion which said no benefit is to be had from the use of systemic antibiotics or vitrectomy unless visual acuity deteriorated to light perception. So what does that mean essentially? It means that most eyes, that vitrectomy on eyes with poor but greater than light perception became the exception rather than the rule. So most of the eyes that finally went on to vitrectomy were eyes which really had very little fighting chances because they were so advanced in the infection. So we're essentially operating on a dead body. The surgery was carried out too late. Now, we know from our general studies, even a first-year medical student knows that when you have an abscess, you drain it because it's an encased suppurative event, and draining the abscess will lead to healing. So what is present in an abscess? Well, you all know better than I do that bacteria, enzymes, cells from the body's immune response, inflammatory agents, whether they're mediated by cells or chemical agents, all contribute to this soup of toxic substances which are present within the abscess itself. Now, if the abscess is in the eye, obviously intravitreal antibiotics may succeed in destroying the pathogenic agent. And that is not even always the case because, as you all know, sometimes you have to repeat intravitreal antibiotics at different intervals. So first day, third day, and so forth. But even if they work, they will not prevent the retinal damage, which is determined by the immune response and bacterial toxins and enzymes. So the retina's functional recovery is actually impaired by a damage which can be potentially prevented. I would like to drive home a point. Endophthalmitis is a dynamic event. Sometimes we forget this, and we tend to classify it in a different way. Actually, it is a dynamic event, meaning that it has a tendency to progress. So when we have a patient and we diagnose an endophthalmitis and we use the terms moderate or severe or this is actually misleading. What we should be saying is it is early, so we caught it early, we're fortunate, or it is advanced, because we know that something which we think is moderate is actually an early stage of the endophthalmitis, which will progress and it will become severe or advanced. So it is important to keep this in mind. The time that we waste or lose between the diagnosis and the intervention gives the bacterial population the opportunity to replicate. And we know that this takes place in an exponential fashion. So that if you see an endophthalmitis which is early, or as most people say, moderate in the morning, you may have a very advanced or severe endophthalmitis by the time you take this patient in the OR, whether to inject antibiotics or to perform a vitrectomy, simply because you had to finish your cataracts. So that eye will have a lesser chance of recovering because we have waited several hours before intervening. So what's the rationale for vitrectomy? The rationale for vitrectomy is essentially that of removing the infective agent more quickly and efficiently than could be achieved with antibiotics. You're scooping out the bacteria. And you're also removing all the inflammatory component which we talked about before. If you don't do vitrectomy, you will have limitations to the visual rehabilitation. And you may end up having the need for reoperations more commonly. And it's interesting to see that in the early vitrectomy study, EVS, in 1995, the number of patients that required surgery was greater than the in the group that was not treated with vitrectomy, was greater than the number in the vitrectomized eyes group. So where is the weak point in the EVS study? Well, I think essentially there was a fear of intervening and determining a retinal detachment. And because of this, the protocol also prohibited the creation of posterior vitreous detachment and limited the amount of the vitreous removed. What the EVS study said, at least 50% of the vitreous must be removed. So if you're saying 50% of the vitreous, what you are removing essentially is the anterior vitreous. You're not reaching down to the retina. So is that a real vitrectomy? Will it really help? I have my doubts. Was this fear justified? Well, again, the incidence of the retinal detachment in the EVS study in the non-vitrectomized group, we had an incidence of retinal detachment which was 2.5 times the incidence of retinal detachment in the vitrectomized group. So it wasn't justified then, and even less it's justified today, obviously, because there have been such massive technical improvements in surgery. We have better machines, we have flow control, the cutting rate, we have an improved fundus view. The early surgeons, and I unfortunately am one of them, because that means that some years have gone by. We didn't have efficient lighting systems. We didn't have wide viewing systems. So obviously it was a very difficult surgery, much more difficult, but also dangerous than it is today. So today I would say that there isn't a justification really for this fear of determining a greater incidence of retinal detachment by vitrectomizing a patient rather than not vitrectomizing a patient. So take home message number one: vitrectomy is a safe, common sense approach to endophthalmitis. And the numbers are there to tell us this. What about the timing? Well, as I said, if we have early, and again, I will use the term improperly, mild cases, I think an attempt can be made to treat with intravitreal antibiotics. However, these patients should be watched closely for the next 24 hours. So that create a problem for many places that do not have either the possibility to have the patient staying with them. For example, many hospitals throughout the world, certainly in Europe and the United States, no longer have facilities for the patients to stay overnight, ophthalmic patients. We no longer have beds in our wards, so we always have to look for an extra bed somewhere else. The patient is out of our control, really. It's difficult to have an access. For example, if a patient is accepted on a ward which is 5 floors away from the ophthalmology department. So, or the patient may not want to stay. So it is difficult to follow these patients. You have to be pretty sure that you're going to be watching them if you take this approach. The more severe cases, and certainly all the cases which are associated with intravitreal injections, should be treated, in my view, immediately. Visual antibiotics, I think, have a role. They should be considered as a temporary step to limit the damage that germs are doing, so to slow down the growth of the germ population while preparing for vitrectomy. And let me just remind you that if you are going to be using intravitreal antibiotics, you also need to perform a vitreous tap first. Otherwise, obviously, you will have no results from that eye. Is there a difference between post-cataract endophthalmitis versus post-IVT endophthalmitis? Yes, there is. We have completely different conditions. The agent is generally different, but the progression is also different, because here we do not have the barrier which is offered by the lens and the iridolenticular diaphragm. We are just placing actually the germs right straight on the retina. So many times we have an intense vitritis and retina damage associated with an IVT, while the signs in the anterior chamber are very, very mild. We only see some cells, we can see some reaction, maybe a small hypopyon, which is misleading because most of the problem is right behind the lens in the vitreous cavity. So the approach must be different as well. Message number 2, vitrectomy will be early. It should not be delayed. What about the method? I think there are 5 important steps to remember. There's some others, but 5 steps are important, especially for beginners. So first, you have to remember that you're proceeding from the anterior part of the eye to the posterior part of the eye in a systematic way, cleaning and clearing your view with each step. This may seem very elementary, but it is essential, because if you do not get a clear view of each different layer which you're approaching, you will not be able to perform a proper vitrectomy. I can tell you that only recently I had a vitrectomy. I had an endophthalmitis case which was associated with an IVT. I could not get a clear view. The cornea was clear. There was no fibrin, or there seemed to be no fibrin in the anterior chamber, but still I could not get a clear view. I then went, and there was no reason for this. I just gently washed out the AC, and I found that it was a very fine deposition of cells on the IOL, which created this impediment in seeing the posterior pole, after which it was much easier to proceed. So even in inexperienced hands, you can have cases which, again, can be somewhat misleading, and you must always keep this in mind. We want to proceed step by step, layer by layer. Each layer has to be absolutely clear so that you can proceed to the next underlying layer, going from front of the eye to the back of the eye. So this is something which has to be kept in mind. And to do this, obviously, you may have to remove the epithelial haze from the cornea. You may even have to substitute the cornea in extreme cases. And you have to remove the cells and the fibrin from the anterior chamber, as I've just told you before. A second step, which I think is quite important, is to open the posterior capsule. So you can proceed with a capsulotomy, you can call it capsulectomy, whatever you prefer. Just try to punch a hole with your vitrectomy probe in that posterior capsule. And the reason for doing this is that you will get not only improved visibility, which is an essential step, but it will allow the penetration of antibiotics in the capsular bag. Thus, you're creating a flow of antibiotics which is not stopped in any way by the IOL. And in general, a lot of you ask, should I remove the IOL in these cases? The answer is no. If you can remember to open up widely the posterior capsule, you do not need to remove the intraocular lens. The third step is focused at removing the vitreous. Now, you should always try to perform a wide vitrectomy or vitrectomy. Now, how wide is wide? Well, obviously, here is something which each surgeon must evaluate according to his or her experience and according to the severity of the case. So, how much can you see? We want to have as wide or as vitrectomy as possible without obviously creating damage to the retina. So my suggestion is generally to proceed in a perpendicular fashion in the vitreous, staying on the obviously on the nasal side of the retina, so that if things don't work out, if by any chance that retina is detached and you accidentally eat into that retina, it will be on a side where the least damage may occur. Obviously, we all would like not to get to that stage, so you have to be quite conservative in being aggressive. It's not an easy compromise, but with time, one finds that that he or she learns how to remove the greater part of the vitreous without damaging the retina. Now, a lot of times we forget about the ciliary body. The ciliary body is also quite important. So, because as we saw before, hypotony is one of the greater risks of these eyes. So, cleaning and debridement of the ciliary body is important, and you can do this quite easily. These are pseudophakic eyes, so with
Okay. Ay. Okay. Hi, everyone. We apologize for the technical difficulty. So going back to Dr. Gini's lecture, Dr. Gini.
Yes, I'm here.
Okay,
Yes.
thank you. Sorry again for the technical difficulty.
This is the beauty of being live. I think it's normal, and I didn't say that. I think this channel is amazing. Really, it's something which should be taken. The possibility of just tuning in and having these lectures for your members is absolutely stunning, and I think that. The Philippine Vitreo-Retinal Society is doing a great job in this. Congratulations! But that's okay. So that's something which just came to my mind. It's really a great service that you're providing. So going back to where we left, I think it's important to highlight the method. So you want to obtain. This is a patient, as I said before, which had cataract surgery. It's an old case. It's 2004, I think, or 2005, but the principles stand the same. The patient had a suture. In those days, cataract surgery surgeons would use sometimes a suture, roughly a 10 oz nylon suture. And the reason for that was because we didn't do beveled incisions, corneal incisions, or sclerocorneal tunnels, or sometimes the tunnel was slightly burned because the instruments were not as good as today. Anyway, that's the past. The fact is that the patient had a suture in place. He did not have the suture removed. It eventually broke and led to this corneal abscess. And it's interesting because the patient only had this one eye. So when he realized that the vision was deteriorating so conspicuously, he asked his son, this is an elderly patient, to take him to hospital. And this is what we found. Now, obviously, this eye is not going to have a clear vision, whatever you do to the cornea. And the priority here is to save the retina and the eye, and the cornea is just an impediment. So what we do is we use temporary keratoprosthesis, and I use a trephine, which is good in this case because a barren trephine would not have had a suction on this chemotic conjunctiva, so it would have been very difficult to use. And this gives a good cut, and we remove the fast forward, we remove the cornea, and we place TKP. This is put in place with a few sutures, and then we use iris retractors to obviously give us a better view of the fundus. And you see that we're going down perpendicularly on the nasal side, and we slowly reach the there we go. We slowly reach the posterior pole. And as I was saying before, it's important to reach the posterior pole because once you have, you can actually use the retina as a guiding a plane to move centrifugally to the periphery of the vitreous, and this will allow you to have a greater safety in performing your vitrectomy. This is the patient's eye 6 months after the procedure, and I believe his visual acuity was 0.3, so the patient was quite happy. So the fourth step, which I was mentioning, is the removal of the hypopyon. Now, we know that these patients are patients which are very unwell. They feel very sick. they have pain, and so generally they don't get around much, but they lie in bed, and they lie in bed flat. So most of the things we would not like to deposit on the retina do deposit on the retina because of gravity, and you have the formation of a hypopyon on the macula. So one tip is to tell the patients to, if they lie in bed, to have a few pillows behind the back to keep them in an upright position, a sitting up position. Now, we obviously would like to remove this hypopyon on the macula. However, the removal of the posterior hyaloid can be very dangerous. I personally do not like it. And so I have devised a different technique, which I called macular fenestration. And this is essentially what it consists of. So the usual steps: removing the fibrin from the anterior chamber, the capsulotomy I was telling you about. And here we have reached the posterior pole. We have done a good job at cleaning the peripheral vitreous. And now we are faced with this deposit of pus on the macula. And we know that the hyaloid is actually representing a barrier, in this case, to the penetration of the antibiotics on the macula. So what do? We simply open up the hyaloid rather than removing it as we generally do in conventional surgery. Because you see here that the hyaloid is very, very attached to the retina, especially on the vascular arcades. So if you're attempting to remove this thickened inflammatory hyaloid, you would probably determine a retinal tear. So what I've done here, I've simply opened up the hyaloid just over the macula where it really matters, and I've done nothing else. So not risking any retinal tears. Another final fifth step, which I would like to highlight and which I advocate, is the use of antibiotic in the infusion throughout surgery. So you get your tap with the infusion having no antibiotic. After you've done that and you have your sample, you can introduce antibiotic in the infusion bottle, and you carry out the whole procedure with a continuous infusion of antibiotic. Now, why is that important, at least in my view? Well, it's important, one, because there is a better diffusion of the antibiotic. The infusion liquid flows wherever the vitrectomy probe goes. So in the anterior chamber, in the bag, in the vitreous cavity, and so on. But it's also important because at the end of the procedure, you have a known and predetermined antibiotic concentration, which is independent of the vitreous cavity volume. Whereas if you're adding the antibiotic at the end in a predetermined volume, you have to deal obviously with the volume size of the vitreous cavity, which may be very different according to different eyes. So the dilution, the final dilution you're obtaining is very different, and it's not constantly known. My take-home message number 3, therefore, we said perform vitrectomy, perform early vitrectomy, and number 3 is perform complete vitrectomy, or as complete as possible with the techniques I've just illustrated to you. So, do we use silicone oil all the time? It's not mandatory. We can talk about this. We have seen certain results with the EVRS study. It seems that not using the silicone oil tamponade is better. Obviously, there are times when you need to use it if you've determined a iatrogenic tear, or if you feel that you're not comfortable with what the vision of in the eye will be following the surgery. Silicone oil is a useful device. But generally, I would say it is better not to use it. So to summarize, I think you should now consider the golden standard in endophthalmitis being early and complete vitrectomy, and I would really urge you to set aside the early vitrectomy study and consider the early complete vitrectomy technique to be your standard from now onwards when you're faced with endophthalmitis. Thank you so much.
Thank you so much, Dr. Gini, for that comprehensive and very informative talk. We will now open the floor to questions. You may post questions in the chat box in YouTube or alternative. Okay, so as we are preparing for the open forum, let's first look at the results of the Slido poll. We asked our audience, what is your threshold for doing pars plana vitrectomy in endophthalmitis cases? The options are vitreous haze of grade 4, visual acuity of light perception, presence of any vitreous haze, or any decrease in vision. Dr. Roy?
Okay. Let's see. Okay, here, back. The results showed about half of those who answered the poll would choose to do PPV once they see a vitreous haze of grade 4. I think that's an interesting case answer.
Okay, Dr. Gini, may we ask about your opinion and about the poll? What's your threshold?
Right. So let me just say that I'm very happy to see that most of the surgeons in your country are moderately aggressive, which is good. Very good. Yes, I would say that I would certainly go along with vitreous haze of grade 4 or more. May I just say that that today we consider performing, at least in Europe and in the United States, floaterectomy. So we remove floaters. Why should we not really deal with endophthalmitis as soon as possible? So my threshold is very, very low. Very low, Joan. It's very low. Roy, what about you?
Yes. Hello. Yes.
Yes. What's your threshold, the two of you?
Actually, I have only a few endophthalmitis cases, but I do remember one that we did vitrectomy years back when I was still a newbie in the retina. And then what happened was, I think I just thought we had to do it because it was a whitish haze. And from the history, it seems like there was a hemorrhage. But then we decided to do a vitreous tap, and it turned out to be a candida. So it could be different. So sometimes I think the vitreous tap has to be done first, then the antibiotics come.
Okay, thank you, Doctor. So I answered the same thing, a vitreous haze of grade 4. No? So we have several questions from Slido. So I'll start with the first question. Dr. Gini, in chronic endophthalmitis with no growth isolation, would you do PCR test or surgically manage the case by removing the lens and do pars plana vitrectomy?
Right. So chronic endophthalmitis, how would we know that it's chronic endophthalmitis and not uveitis, for example? But regardless, because if there's no growth, you have no evidence that there is bacteria. So, but regardless, I would definitely approach this case with PPV because even if it were not endophthalmitis, but it was simply uveitis, then PPV would be an indication for the removal of vitreous opacities. And then I could use PCR where available to enhance the results and possibly get some sort of answer. Also, if his endophthalmitis should no, again, it's no growth means that you have not have any evidence, if I understand correctly the question. So you have no gram stain, you have nothing to prove that this is really endophthalmitis. So again, you would be differentiating between endophthalmitis and uveitis, and so you would need to look at histology for example. You may want to see if there are any malignant cells, if you have a lymphoma or something of the sort. So yeah, definitely PPV, definitely PCR, absolutely not remove the lens, because there's no point at this case for removing the lens. If you did isolate, once you've opened the posterior capsule and you've isolated germs from the lens, so in other words, we're talking P. acnes or some other slow growing germs, then yes, at that point, you may consider going back in, and if the problem has not solved itself, removing the lens. But this would only be done in a second, as a second approach, not first time approach.
Thank you. Dr.
And
Roy?
for the next question, what is your go-to first-line intravitreal antibiotics for chronic endophthalmitis, Dr. Giampaolo Gini?
Again, vancomycin, I think, is the golden standard for most surgeons. And yes, vancomycin and KEF, those are the antibiotics which I always use.
Joanne?
Okay, thank you. There's another question. Have you had any experience with endophthalmitis post-silicone oil injection?
Before I answer this question, can I just make another point? One of our members, and I think you will remember attending, was it last year? Yes, I think it was in Lisbon, where a poster was presented with the use of iodine in the infusion solution at the concentration of 0.025, and the results were very, very encouraging. So even in those cases where you have antibiotic resistance, this could be a novel way of approaching the problem. Anyway, the answer to the endophthalmitis silicone oil, no. I have not had any experience with that. No, fortunately, no. It could happen. I imagine that the question was formulated by someone that uses medical grade silicone oil. Nowadays, we don't use industrial grade silicone oil anymore. But it's sometimes you can have contamination of the silicone oil. Yes, we have seen that, but not personally.
Thank you.
Again, another question. What is your preferred management in addressing post-endophthalmitis hypotony?
All right. So if we see that the hypotony is very marked, there's not much you can do except perhaps trying to fill the eye with silicone oil. That can prevent the eye from becoming phthysical. Another approach, if the hypotony is not particularly marked, you can try to revisit the ciliary body. If that is detached, especially if you can prove that with UBM, you could try reattaching that or debriding the ciliary body.
Thank you. Another question. what is your routine workup for endogenous endophthalmitis? And do you attempt to find the source?
Yes, well, this is something which generally it does not really, let's say, concern the ophthalmologist. We make a diagnosis, so we find that there is an endogenous endophthalmitis. We identify the agent, can be generally or quite often it is a candida, and then it is up to really the medical people to find where it comes from. But generally, well, it's the usual routine. So blood cultures and CAT scans. I remember we had one recently who was an elderly gentleman, not a drug addict, that had a catheter in place that could have been the origin of a candidosis. So we found that he had this candida endophthalmitis, and eventually a CAT scan showed that he also had a brain repetition of candida. So he was treated accordingly. But that is something which the ophthalmologist, at least in this part of the world, doesn't do.
Thank you, Dr. Giampaolo. Another question is, what would you like? We would like to ask your opinion in the use of intravitreal steroids together with intravitreal antibiotics at the end of the vitrectomy surgery.
Yeah. Before I go on, let me ask you: am I going to? Is the audio good? Am I speaking too fast? Is it good? Can you hear me distinctly? Yes.
It's
Very
perfect.
clear.
Good. Okay, great. So this is something that is very, very individualistic. So each surgeon will do what they think best. I don't think there's any contraindication to the use of intravitreal steroids. They can be used, certainly. I personally don't use them anymore. I used to, but I just don't do that anymore. Because of limitations to the things we can use in which are not authorized in the operating rooms, rather than a scientific belief that they don't work. So definitely, if you work in an environment which allows you the use of steroids, by means, yes. And as I said before, I don't like to use antibiotics at the end of the surgery. I just use them all throughout the surgery.
Okay. Thank you. For cases that were injected with silicone oil, was there any retinopexy done? Were there any identifiable breaks, or was it assumed to have a break?
Okay, we don't have that information. That information was not given to us. You realize that the survey already had many pages to it, and we felt that people would just be so fed up filling in all the details that we did not want to add anymore. I presume that there may have been a break. I presume. Again, the main reasons for using silicone oil to me today would be only two. One, if you have a break, or presume you have had a break. I cannot see anybody performing retinopexy, any other maneuvers on the eye. And the other reason would be, again, if you believe that your vitrectomy has not been very thorough, and you think you will have a lot of cloudiness of the vitreous the following day, you may want to have a clearer view by introducing silicone oil. But as a general rule, I would not. Does that answer?
Yes, thank
Yes,
you very
thank
much.
you, thank you. Okay, so
And
we have more questions from YouTube. In cases of endophthalmitis with a choroidal abscess, is there a specific way to manage these cases?
Endophthalmitis with a choroidal abscess. So is in other words, you were looking at something like scleromelacia, maybe because you put a buckle or something of the sort. Is that the question? The approach is essentially the same. Obviously, you have to deal with the abscess, the scleral abscess, targeting that before you perform your vitrectomy. So, in other words, if you have, let's say, scleromelacia due to a buckle which was not removed, and then you have gone on to develop an abscess which has given you an endophthalmitis. Obviously, you have to repair the outer shell first, and then proceed with vitrectomy.
How about for patients with endogenous endophthalmitis and choroidal abscess?
I've never come across this sort of patient, so I can only give you an educated guess. Again, they have to be dealt with as two different conditions which come together. So uh, in these cases, you would definitely need the support of systemic antibiotics, because we know that that obviously you need something which goes beyond the reach of intravitreal antibiotics. So this is a case where general antibiotics would be mandatory.
Okay,
Another
thank you.
question.
And yeah, I think we have the last question from the VRSP. What antibiotics do you use in the infusion, and what is the concentration of the antibiotics in the infusion?
Right. So what I try to achieve is I use vancomycin and I use KEF, ceftacidin. I can never pronounce that properly. Yes. And or cefuroxime. So the concentration of vancomycin is slightly higher than what is generally used according to international protocols. And I have found that not to be harmful in any way. Vancomycin, I use 1 milligram per mil. So I will have at the end of the procedure 5 milligrams or 6 milligrams inside the vitreous cavity of vancomycin. Uh, KEF, I generally use 0.2 2 milligrams per 0.1 milliliter. So it comes out to about a standard concentration inside the vitreous cavity, similarly to vancomycin. So the idea is to have standard concentrations rather than adding at the end, where you don't have that sort of certainty of having a predetermined concentration within the eye.
Okay. Is that the last question, Joanne?
Yes.
Okay. Unfortunately, that is all the time we have. So thank you for sending in your questions. And thank you, Dr. Giampaolo Gini.
Very welcome.
We'll try to address your questions and send you the replies. So, Joanne?
Okay, so thank you so much again, Dr. Gini, for that
Very welcome.
comprehensive lecture. Okay, so again, we would like to thank our partner, Bausch & Lomb, for supporting this episode. Please welcome back to our screens, Bausch & Lomb Technical and Support Manager, Mr. Emmanuel Flores, to talk about the Stellaris PC pressurized infusion system. Sir Manny?
Thank you very much. Okay, let me open my slide. Okay, good evening to everyone. And also, I will turn off my video because I have a slower internet with the video on. Is that okay? So good evening to everyone. Thank you for this opportunity. Allow me to discuss about pressurized infusion, what makes pressurized infusion effective, and then we will compare it to our standard gravity. But first, we need to have a vitrectomy machine with the pressurized infusion capability, such as the Stellaris PC from Bausch& Lomb. The Stellaris PC vision enhancement system has a very stable fluidics. In posterior mode, you can use the foot pedal like an accelerator, controlling the vacuum to manage the flow. You can even use the dual linear foot pedal. This is a new technique wherein you can control two parameters at the same time. For example, you have a linear vacuum using your pitch, and at the same time, you have a linear vitrectomy cut rate in your yaw. This is the swing movement in the pedal. Our purpose is to reduce turbulence. In order to reduce turbulence around the probe, or in order to have a little tissue movement during vitrectomy, the machine parameters are set to higher cut rate. Normally, it is raised up to 5,000 cut per minute. So with the high cut rate, smaller bits of vitreous are removed, causing a more stable chamber throughout the surgery, and thereby reducing turbulence. And this allows for safety. Because of the cutting speed increases, the flow will also increase, and so as our vitrectomy time is reduced. And third, because we intend to have a faster wound healing, we go to 23 to 25 gauges of probes or sutureless. Now, because of these new improvements and increase in machine parameter, there is a need to match and improve the infusion pressure. As we all know, infusion pressure is considered one of the most important parameter that will affect our fluidic, aside from our vacuum, cut rate, port position, gauge size, and surface area of the infusion cannula. The vitrectomy machine should be able to have the ability to provide faster response, high vacuum setting, good retention, and accurate IOP control and stability. Also, let us compare first the two kinds of infusion that we have at the moment. First is the gravity infusion. This is the oldest and yet reliable method. We can actually see the irrigation in the drip chamber of our macro set because of gravity. And with the Stellaris, we have a 30 to 140 centimeter of water as our unit of measurement. This is equivalent to 22 to 150 mmHg. The infusion pressure is proportional to the IV bottle height. And so as our bottle height is increased, the more we have, the more pressurized infusion or infusion pressure we have. However, we also need to consider the effect of atmospheric pressure. In our macro set, you can see a small vent. It is a filter, it is a valve check. And so as the atmospheric pressure goes inside, we have built an atmospheric pressure inside the BSS or plastic bottle. And using gravity, we have a pressurized infusion pressure. And so the problem with this configuration, one is the slow vertical movement of the IV bottle. And this will reduce our response. And because this is a gravity, it is just an estimate of our infusion. It is slow compared to pressurized. So here comes the pressurized infusion. We termed it Air Force infusion from the Stellaris PC. This time, pressurized air is being forced inside the BSS bottle or glass bottle, and this allows us to have the infusion pressure of 0 to 150 mmHg. A new macros drip set or metal spike tube is now used, such as this, and the vent is now connected to our air or airport. What happens next is that air goes inside the plastic bottle and introducing pressure that allows our infusion. Air venting is also possible because of our method of introducing air in the bottle. So what is air venting? Venting is the ability to reduce the compliant influence in on chamber stability in order to achieve correct bottle pressure more quickly. We do venting, the machine is doing an automatic venting every time we do a priming, we do a reflux, or when we immediately release the pedal, the machine automatically does venting. What happens with the pressurized air for AFI is that air venting is now faster because it is vented instead of fluid vented. And so, how to configure our Stellaris machine using the AFI packs? And so, first step is to, of course, we use the zero bottle hanger. This hanger is now set at 0. It is much lower than our bottle hanger. Next is we use a glass or plastic bottle as our irrigation. Third, of course, we will need to use the AFI packs. And here you can see the metal spike tube, which is a longer macro set compared to our standard gravity. And last, we need to configure our Stellaris machine so that we will be in the pressurized infusion mode. So from the left screen, you can see we have a IV pole and fluid air exchange. But switching to pressurized, we will only have the fluid air exchange or AFI setting. And now we connect our tubings. You can see in our screen that our AFI port is over here, and next to it, air is now split, one going to our infusion cannula, and the other goes to the AFI spike bottle. So here is a surgeon setting of a actual setting from Dr. Ersinwe. This is in 25 gauge. Our default setting, air infusion is set at 35 mmHg using a dual linear vitrectomy cutting method with a maximum of 200 vacuum and a cut rate of 1,000 to 2,500. Okay, so what makes pressurized infusion effective? In summary, number one, it is a new and improved technology that allows stable and predictable fluidics. It is not an estimate anymore, but it is a predictable. It is time-tested and well-accepted by surgeons worldwide. Second, it is more responsive than gravity type because we are not considering the atmospheric pressure anymore. The air is being pushed inside the bottle, and so we have a better IOP control and stability. And last, we have a faster venting compared to gravity. This will minimize complication and peace of mind during delicate surgery. So as I end, here are some clinical experiences and feedbacks from surgeons who have been using the AFI packs. According to Dr. Anzures, she noticed immediate IOP control and infusion stability using AFI packs. Very easy transition to pressurized infusion. Doctora Calendrino also experienced better IOP control in her surgical environment because I can command the infusion setting, as she said. Using AFI packs gives me a more accurate IOP control. And lastly, according to Dr. Ersinwe, she detected a predictable IOP from start to finish, and that gives her a peace of mind during complicated and delicate procedure. So with that, thank you very much for your attention and good evening.
Thank you, Mr. Manny. And
Thank you.
just a few reminders before we close the session. Please scan the QR code to receive your certificate of attendance. You can also click on the link posted in the chat box on both Facebook and YouTube. The form will be accepting responses for about an hour.
Okay, so Dr. Roy, to sum up our evening, so for cases of endophthalmitis, the earlier we intervene, the better the initial vision of the patient is, the better the visual prognosis. Prognostic factors for improvement include an initial visual acuity of counting fingers or better, clear cornea and absence of pain at presentation, and vitrectomy as opposed to intravitreal injection as treatment. For a successful vitrectomy, it is positively correlated with using smaller gauge and negatively correlated if there is a retinopathy or maculopathy or the presence of silicone oil tamponade. Endophthalmitis cases of any nature should be treated as a surgical rather than a medical emergency. Vitrectomy removes the bacterial agent as well as the immune response. Now we have better machines and better visualization. Hence, we can do more complete vitreous removal. Early complete vitrectomy should be the standard for endophthalmitis. Again, thank you so much, Dr. Gini, for your wonderful talk. To our viewers, we hope we learned a lot. You learned a lot, no? And we can manage our patients better.
Thank you.
Dr. Roy.
Thank you so much.
And thank you very much, Dr. Giampaolo Gini. And for the VRSP, that is just a preview of what we will see if we attend the EVRS meetings in the future. So if they missed the previous episodes of the VRchannel or would like to watch them again, the episodes are available for viewing at the VRSP website. Please visit vrsp.org.ph.
Okay, so to the
Thank you.
VRSP members, see you on March 20 for our first quarter meeting. Thank you again for joining us tonight. See you on April 17 at 8 p.m. for our episode 11. Dr. Steve Charles, one of the pioneers of the vitreoretinal surgery, will talk about diabetic tractional detachments and macular patch grafting here at the same channel. See you.